Hi guys, Dr. Hart here. Today I'm going to talk about bipolar and related disorders. So this introduction is just covers some of the basic terms that you should know for this content. Okay, so your mood, a person's mood are the emotions that they're having. They may be sad, glad, angry, anxious. But the affect is how they express those moods and how your patient is going to present to you, depending on what mood they are going through at the time. So if they're having happy, obviously going to show that. Depressed mood, the affect is going to be flat affect, no expression. And a lot of times, the depressed person is going to be slumped, no eye contact, looking at the floor. They're not looking at you. They may have a hoodie on. They're looking very, very sad. They're not taking care of personal hygiene. So those are some terms to start out with. Another term is mania. That's very important in understanding bipolar disorder. These are changes in mood. These are unregulated mood swings. They are abnormal feelings. They may be feelings of grandiosity. I am better than you. I'm better than everyone else. I'm hyperactive, racing thoughts, the person that can't stay, not able to stay on one thought when they're skipping to the next thought, accelerated speech. Someone with bipolar in the manic phase or in the mania phase is going to be talking very fast. Their thoughts are all over. They can't concentrate. They can't literally physically sit still. And it's going to be very difficult to get them to slow down. And they're going to be having all kinds of grandiose thoughts, inflated self-esteem. I'm better than everyone else here. And this may be as these moods may be from the bipolar disorder, or they may be from other disorders. So affect can be congruent or non-congruent, so you would document in the chart. So if the person is talking about the death of their father or the death of a loved one and they're laughing hysterically, that is a non-congruent affect, and that's what you would document in your nursing notes. You would also document your interpretation of the patient's expression. You're going to be very objective. Patient is sitting with head down, no eye contact, and you're going to describe the personal hygiene, describe the personal appearance of the person, remain objective as possible in your documentation. The affect might be blunted, agitated, restricted. And again, as I mentioned, flat affect, not showing a flat affect or blunted affect, pretty much the same thing, not showing any emotion. These are part of the mental status examinations that are used in psychiatry. Okay, so here we go with bipolar disorder. These are the characteristics. There are mood swings, up and down, delusions, hallucinations, might be having delusions. Delusions are false fixed beliefs. Everyone's against me. Delusions are there is someone in my attic who is spying on me. There are people conspiring against me. And the mania, extreme periods of euphoria. Okay, euphoria is happiness. So they may go from um, being really happy to really sad, really mad, all at the same, in the same sequence. With mania, there may also be endless energy, increased libido. The mood is going to be labile. When you hear the term mood lability, that is mood labile. That's a mood that's all over the place, changing very rapidly from sad to mad to happy and back and forth. Pacing. There may be pacing with mania, pacing along the floor. And again, I mentioned grandiosity. I'm better than you. I'm the most world's perceptive attorney. So I'll start with there are different types of bipolar, bipolar 1, bipolar 2, and cyclothymic. I'll start with the most serious, and then I'll go to the less serious. Bipolar 1 disorder. Okay, so this patient with bipolar 1 disorder is having a manic episode, and they have a history of having one or more manic episodes. And this is how the person is diagnosed in the DSM-5, which is the Mental Health Psychiatric Statistical Manual. This is what the psychiatrist uses to diagnose patients with whatever disorder they have going on. Bipolar 1 disorder, they may be in the manic phase, they may be way up here, and then they're down here, way depressed. Okay, so they're fluctuating. Bipolar 2 disorder is a little less serious. They haven't had enough episodes to be diagnosed with bipolar 1, or they've never had a full manic episode, they've never been hospitalized. Hypomania is another term. That's a lesser or milder degree of mania. Not severe enough to cause great impairment in their social and occupational functioning. Does not require hospitalization. A lot of these mental health disorders are rated or come about for the person when they are having trouble with social interpersonal relationships and or having trouble with occupational functioning. So they're not able to keep a job, which means they become homeless, jobless, have no money, and that becomes very severely dysfunctional. Cyclothymic is the next lesser mental health diagnosis for bipolar disorder. This has a mood disturbance that has lasted at least 2 years, a lot of elevated mood, but not quite reaching to the point of a manic or hypomanic episode. This is someone who may visit a therapist and be working on themselves and doing very well, may or may not need medication at this point. So this is lasting at least 2 years with numerous periods of elevated mood, not quite meeting the criteria for hypomanic or episode. And again, this is the DSM-5 is used by the psychiatrist to diagnose these bipolar disorders. Bipolar disorder may also be substance or medication induced. patient may be intoxicated or going through withdrawal from a substance. For example, alcohol, amphetamines, cocaine, hallucinogens, inhalants, opioids, sedatives, anxiolytics. I will go over another other lecture about the different types of substances, different types of substance use and abuse. I will also cover many of the mental health, psychiatric medications on another lecture. Bipolar disorder can also be caused by another medical condition, such as thyroid disorder, stroke, traumatic brain injury, multiple sclerosis, lupus, or AIDS. So, bipolar disorder can be genetic. There can be physiological influences, which can be dysfunctions in the brain. I will talk about briefly the medications that can cause an onset of bipolar symptoms. Can be steroids that are used for multiple sclerosis and lupus, amphetamines, antidepressants, high doses of anticonvulsants, and narcotics can begin a manic episode. And then there is also the psychosocial theory that bipolar disorder may be linked with childhood trauma. If the person was verbally, sexually, or physically abused as a child. Okay, so these are the different, just three different stages of mania. First one, hypomania. Not severe enough to cause any great impairment in social or occupational functioning. With hypomania, the activity and behavior, they may show increased motor activity. They're extroverts, they're very outgoing people, very sociable, and they may have a lot of acquaintances, but not necessarily any deep interpersonal relationships. They're going to have superficial relationships. They talk loud. They may be talking loud and often inappropriately, and also increased libido is common, which is a higher sexual desire. Stage 2, then they're getting into acute mania, continuous high, the flight of ideas, distracted, very hard to concentrate, activity, sexual interest, more sexual interest, energy, and may go for long periods without any sleep. This person in the acute manic phase may be having grandiose delusions of persecutions, everyone's against me. I'll talk more about delusions of persecution when I get to subjects like schizophrenia. So, continuous flow of accelerated pressure speech, where it's very difficult to speak to this person and keep their attention long enough to even get the story of how they were admitted or why they were admitted. Hygiene and grooming may be neglected, dress, organized, disorganized, flamboyant, or bizarre dress. Excessive makeup and jewelry are also common in this stage. This person is going to be coming up with many grandiose or great ideas for inventions. There may be excessive spending, excessive shopping, and as this will be also high risk for sexual behavior. Delirious mania, stage 3. The mood is very labile, all over the place. As I mentioned before, panic level, panic attacks at this point. Also, extremely distracted and incoherent speech at times. Mood lability again. So in the nursing process, these are some of the nursing diagnoses and some of the goals. Risk for injury, imbalanced nutrition. The imbalanced nutrition comes as a result of the patient is not able to sit still long enough to eat, so they end up with imbalanced nutrition. For that, not being able to sit long enough to eat, the nurse may offer small snacks and drinks that the patient can have as they're walking around, so that their nutritional status is maintained. So the nurse can provide a high protein, high calorie, nutritious finger foods and drinks that the patient can use while they're walking around during the day, because they're having a hard time sitting for any length of time in order to eat a whole meal. They're in that hyperactive state. Okay, nursing diagnoses I like to cover: risk for violence, risk for injury. They're very easily agitated. They're not having any control over their movements, so they are high risk for falls. High risk for not getting along with other residents or patients in the unit. Okay, high risk for getting into fights. Nursing interventions for the manic phase. Try to assign the client to a private room, because if you can, the patient may be easily triggered by other patients across from the nurse's station or closer to the nurse's station. Try to decrease the stimuli, lower the lights if you can, allow them to have the lights off in their room. Try not to subject the other clients to this overactive behavior. Priority in this case, priority with all patients in all units, is to provide yourself as the nurse and the client with a safe environment. Okay, so this is the care plan, just a quick care plan for the patient in the manic phase with the imbalanced nutrition, less than body requirements, nursing diagnosis. The goals would be to for the patient to eat a well-balanced diet with snacks to prevent weight loss and maintain that nutritional status. Provide patient with high protein, high calorie foods. Medication management, I'll talk about the main medication for bipolar disorder. So, medication management. The main medication, and I'm going to talk about these when I cover psychopharmacology. The main medication used for bipolar is lithium, okay? And the side effects are very serious for lithium. If the lithium levels must be drawn, the doctor will order blood draws when your patient is taking lithium. Lithium is a salt. It was discovered way back when there were salt baths. So that's why salt baths are still used today, because it was found that it's relaxing, helps a person's mood. Okay, and so I'll talk more about that. I'm going to list the symptoms of lithium toxicity and the levels that you should look for in the labs when labs are drawn for a patient on lithium. Okay, signs and symptoms of lithium toxicity when the lithium levels get too high. Ataxia is lack of coordination, blurred vision, tinnitus, ringing in the ears, excessive urine output, increased tremors, and mental confusion. Important, teach your patient the importance of not stopping or don't stop abruptly, even if you start feeling better. And that's part of the problem with many mental health patients. They start to feel better. They don't like the side effects. So guess what? They stop taking their medication. Do not drive, heavy machinery, and no alcohol. You can count on no alcohol with any of these antipsychotics. May cause drowsiness, dizziness. Also very important with lithium, teach your patient to maintain an adequate dietary sodium intake. Eat a variety of healthy foods, avoid junk foods, lots of water, 6 to 8 large glasses of water every day. Teach your patient to notify the nurse or the provider if they're having any vomiting or diarrhea. Vomiting and diarrhea is going to cause a loss of sodium in the system. So these symptoms can result in sodium loss and an increase of lithium toxicity. So if there's less sodium, there's going to be more lithium in the blood. Of course, risk of becoming pregnant while receiving lithium. And I talked about the side effects of lithium toxicity. Also, strenuous exercise can lead to dehydration, puts the client at risk for lithium toxicity. Replace the water and sodium lost through sweating. Diarrhea, diuretics can dehydrate the patient. These are the types of treatment recommended: family therapy, cognitive behavioral therapy for your patient with bipolar disorders. Electroconvulsive therapy is also used in extreme cases where medications are not helping. I will talk about electroconvulsive therapy, or ECT, later on in another lecture. Also, bright light therapy may be used to reset the areas of the brain that are affected. Okay, and so here's the psychopharmacology for bipolar disorder. For the manic phase or for mania, it's lithium carbonate. Also, convulsants are used. Carbamazine is Tegretol, valproate or valproic acid. Lamotrigine is Lamictal, brand name Lamictal, for maintenance of the symptoms. Antipsychotics are sometimes used. Chlorpromazine is brand name Thorazine. So that's a heavy-duty antipsychotic that is a first-line, first-generation typical. And I'll go over all of those definitions and terms when I cover the psychopharmacology. Again, patient and family education for lithium. Take medication regularly. Don't stop abruptly. Notify the doctor if you have any vomiting, if your patient has any vomiting or diarrhea. So now I'm going to talk about, lastly, the narrow margin between the therapeutic and toxic levels of lithium. Lithium levels must be monitored regularly while your patient is on lithium. Normal ranges, I have 0.6 to 1.2 milliequivalents per liter. Okay, your test questions should not be ambiguous. It should be way out of the range, like 1.9. Your patient has a lithium level 1.9. Okay, what are they at risk for? Lithium toxicity at that level, okay? And also teach your patient to report to the doctor or the nurse skin rash, unusual bleeding, bruising, sore throat, fever, malaise, which is fatigue, dark urine, yellow skin or eyes. Dark urine, yellow skin may indicate liver damage. That's jaundice. Okay, so that's it for this lecture. I'll see you on the next one. Take care. Have a great day. Check out my YouTube channel, Nursing with Hart, PhD. All right.